and welcome everybody to this week's Maternity Midwifery Hour. My name's Sue MacDonald and I'm the curator for the Maternity Midwifery Hour and the Maternity Midwifery Festivals, and it's my pleasure to be chairing this evening, which is week 3 of Series 17. And I have two lovely midwives with me, and that's Judith Cutter and Lesley Turner, and here they are, and I'm going to demand them to share a moment of the week. So please, Lesley, share your moment of the week with us.
Thank you.
Well,
I'd like to tell you about my moment yesterday when we spent some time with our very new first year student midwives, and we were talking about careers and the different directions their careers could take. And we're lucky enough to have 2 of our alumni come back and meet them. And it's just really emotional to see our brand new midwives come in, and also 2 of our returners talking about how they felt and their journey since they qualified. So that was really special for us, and hopefully for them. So yeah, that's what I wanted to tell you.
Oh, that's a lot. Thank you so much. That's a lovely moment to share. Is it you sort of as a teacher, you sort of feel like they're baby midwives, but and you see them go through that whole life cycle. And it's very exciting. Oh, that's lovely. Thank you, Lesley. How about Judith? Can you compete with that?
Wow, no, that was it. That was a good one. That's that one. So mine would be from today actually. So we have just completed a lovely collaborative piece of work with the Birth Partner Project. So the Birth Partner Project is a lovely charity that supports women who are in the asylum process or seeking sanctuary and who don't have any support during labour. So they come in and provide that volunteers to support women during labour. And we've just finished this piece of work, and we've devised a flow chart that if any kind of partners wanted to raise any concerns or any praises or anything, and just to enhance the care really that the woman is receiving. So we had a lovely meeting with them this morning, and had just finished this piece of work, and it was just really great, really good piece of work.
Oh, fabulous. And that is so contemporary now with what's going on in the country, which can be very negative, and that's a lovely positive kind of focus on it, on the needs of asylum seeking women or refugee women, and what you're doing for them and the work that's involved. That's wonderful. Thank you so much. Well, thank you for our speakers. We're going to return to them. We'll give them a little break before we come back. And I just want to say a special welcome to those who are new to the Maternity Midwifery Hour from wherever you are in the world. And do share on the chat box with Paul where you're from, because that's always interesting for us here to know who we're talking to. I know we've got some new people, and you may not know that we were born, this maternity hour was born about 5 years ago, on the onset of the first COVID-19 lockdown in the UK, where we couldn't, as midwives and student midwives, meet face to face. You couldn't go on study days or conferences, and you had to be focused on clinical work, obviously, because everything was focused on keeping women and babies and families safe, and also being as safe as possible for you and for student midwives, of course. So the world went a bit difficult, and sometimes it's hard to remember that, and other times something comes back and you think it was such a scary time and we survived it and we did well, but we're having to sort of sometimes pick up the pieces for people like your children, and also students who also experience a sort of a stranger kind of course than perhaps some of us did. Anyway, that initially we did a lot about COVID because that's what the information we needed as practitioners and students. But as time's gone by, we don't talk so much about COVID. We really are looking at lots of different things in maternity and midwifery and trying to sort of refresh our brains and learn new things. And we love you to share. That's one thing. And because we love you to share, we record everything. Now, you'll find if you come to our festivals, everything's recorded. If you come to this, it's recorded. So if you have a power cut tonight, this very night, don't panic, because you'll be able to catch the recording at a later point when it's released next week. And that goes for the festivals as well. You don't have to attend every single session, because you get a lovely box set at the end of it, and you can dip in and watch everything and not miss anything. And I love that as a midwife. I've always loved to get my good value from everything. And we love you to share. And I think you're going to learn things this evening, and it'll be really good if you share it with your colleagues. If that happens to be a student group or your fellow midwives, do share and share the recording and have a chat about it. That helps to cement it in the brain, which is always good from a learning point of view, because then you remember it. If you're doing a revalidation at some point, this is really good and really useful to remember. Now, I'm just going to go a snippety bitty into the news. Now, today is the International Day of the Older Persons, UN. Doesn't say what we mean by older, so that could be for those of us who are over 21, which is good. And tomorrow is the International Day of Non-Violence. Be nice to think it would be wonderful, actually, if we had one day of non-violence, wouldn't it? This whole world's gone a little bit mad. And the 5th of October is World Teachers' Day, and that can be teachers of midwives too as well. Now, I wanted that you'll notice you have lots of resources on your sheet. Some of them are like Embrace report and the perinatal audit report, which is still, I think it's still useful if you haven't heard about it, which gives you a little snapshot of what's happening within maternity care within the UK. And also a report today I came across via Twitter, something on Twitter. This is from the Sands and Tommy's Policy Unit, and this is entitled Not Just an Option, and it's interpreting as an essential component of safe maternity and neonatal care. Now, we have looked at this in the past, so I was very interested to see this, and it's basically saying, guess what? It's not a luxury to be able to communicate with women and their families at a time in maternity and neonatal care. And there's still not enough provision of sign language, for deaf people, but also community language. We've still got work to do. So that was very interesting. And the other tweet I picked up, which kind of links into what we're talking about tonight, was from Dr. Phil Hammond, who said in one of his little tweets, apart from all these reports and reviews going on all over the place at the moment, what we need to do is look at having mandatory safe staffing levels and skill mix in all maternity and neonatal units. And I thought that was, he must have been watching the Maternity Hour, must have known this was coming. So this underlines what we're going to be looking at. And in fact, I'm talking really quickly because I don't want to miss anything. Anyway, just to reiterate, this is on your list, and it's only 80, no, it's 80 pages, no, 42 pages. 42 pages. So be careful if you press print that you know it's going to be that many. But I think it's really useful because it's got things that women have said about what the service they're getting, which always makes, for me, or always makes research and audit come alive a little bit. Anyway, this week we're looking at postnatal care. Now, we always say it's the Cinderella of the service, and I know, some of us, some people don't particularly like postnatal care. I've always loved postnatal care myself because it's a very special time for mums and their babies and their families, and it's scary time for mums with a little tiny precious new human baby, where they might not quite know how to cope with it all. And that's where the midwife's role can come in. And we have got two fantastic speakers, as I've already said, one of whom is going to be talking about postnatal care with a little bit, I think, of postnatal contraceptive services, I believe, because that's her passion. And the other is going to be talking about staffing. So that fits into what the text I was talking about earlier. So I'm going to start off by introducing Judith Cutter, who many of you will know as a consultant midwife for public health and vulnerable families at Cardiff and Vale University Health Board in Wales. And she provides clinical and strategic leadership across areas, including perinatal mental health, obesity and pregnancy, female genital mutilation, women seeking sanctuary, which she was just talking about, and human trafficking, teenage pregnancy. This is quite a big brief, isn't it? Breastfeeding, stillbirth, smoking, substance misuse, and sexual health. She's got a huge amount of experience and involvement with research, including the pool study that was published last year, And she's currently exploring barriers and facilitators to early postnatal contraception uptake. So welcome, Judith. The screen is yours. Thank you so much for joining us this evening, and welcome.
Thank you. I'm just going to share my slides. Let me know if you can. Are you able to see those? Yeah, lovely. Okay. Thank you, Sue, for that. So yeah, I'm going to talk about does fit into the postnatal care. And this is the bit of postnatal care that sometimes as midwives we perhaps forget or we leave off the list because we feel maybe it's not appropriate to talk about contraception so early on after birth. So I'm just going to go through a little kind of just a little overview of what postnatal contraception is and the importance of it. So when we talk about post-pregnancy contraception, we are looking at any contraceptive methods which are in the early postnatal period. So this is the including straight after childbirth, or if after abortion, ectopic pregnancies, or any pregnancy really, or miscarriage, or any gestational trophoblastic disease as well. And it is written into the women's health plans in the UK. It's really explicit in each women's health plan, and this is in all the 4 countries of the UK. It's really explicit that postnatal contraception should be part of maternity care. And it says in the NMC, in the standards of proficiency as well, that actually we should be, as midwives, providing key information around around family planning and postnatal contraception. And recently, the College of Sexual and Reproductive Health, this used to be called the Faculty of Sexual and Reproductive Health, has now changed their name to the College. They have just, hot off the press, they have released a document called, which is a guide for best practice around post-pregnancy contraception. So actually, it's really detailed. So I would kind of encourage you to read this. I think it was just released last week, so they're good documents to read. So just some kind of background, really. So we know in the UK, around 45% of pregnancies are unplanned or ambivalent. And we know that fertility returns within 21 days of birth. So actually, when we're saying go and see your GP at 6 weeks, actually, it's too late. We want to kind of get provision on board prior to that 21 days, really. And we know that 1 in 8 Paris women conceive and continue with another pregnancy within a year of a previous birth. So actually, that's quite a stark number. And almost half of women resumed some form of sexual activity within 8 weeks of birth. Even though, immediately following birth, they'll say it's the last thing on their mind. They really, it's the last thing they want to do is be thinking about intercourse. But actually, when they start to recover and their bodies start to feel back to normal again, they actually, that time goes really quickly. And we also know that almost 1 in 13 women presenting for an abortion or delivery had conceived within a year of a previous birth as well. So that the numbers are there, and actually, so that it does realise that it is a really important topic. Also, miscarriage is the most adverse pregnancy outcome. So, in the UK, in about 10 to 15% of all pregnancies result in a miscarriage, and that was really that was a lot higher than I actually thought. So, this was from the best practice guide. So, that was really interesting to hear that. And we know about 1/5 of women are unable to access their preferred method of postnatal contraception as well. So, we might be discussing it, but it might not always be available for them. And because it's the NHS, we have to talk about money because we have no money. But actually, this is a spend to save, this service. So providing contraceptive service in maternity settings has estimated savings of £32 for every £1 that's invested. So it is a spend to save. It will help kind of save money in the future. So when it's really important that we talk about pregnancy spacing, and again, as midwives, we don't tend to talk about the importance of pregnancy spacing and why it is important. So the World Health Organization recommends birth spacing of at least about 24 months before planning the next pregnancy. And studies have reported that interpregnancy intervals of more than 12 months may reduce maternal risks of anemia, third trimester bleeding, premature rupture of membranes, maternal mortality and morbidity. And within this, what they found is that actually it can reduce the risks of preterm birth, low birth weight babies, small for gestational age, and infant mortality in subsequent pregnancies. So it is a public health issue. And we also, and there's other reports that support this as well. So the methods that are available then. So in the early postnatal period, so before that 21 days, we do recommend if you're going for pharmacological methods, we recommend the progesterone methods. So progesterone only pill, the progesterone only injectable, then the longer acting methods, so the longer acting reversible contraception methods are known as LARCs. And this is your subdermal implant, which looks like I'm not allowed to call it a rod, but it is, which is subdermally, just under the skin in the arm, and that releases progesterone throughout the body, and it releases it for over a 3-year period. So it's a really good method of contraception. The other long-acting reversible method of contraception is your intrauterine systems, or your coil, So your device, so your system is your Mirena coil. So this is with hormone in it, so with progesterone in it. And then the other one is a copper, which is it's not got a hormone in it. The progesterone can last for Mirena coil can last for up to 5 years. The copper one can last for up to 10 years. So really good methods of contraception. One that we don't really talk about very often, but actually is a really good method, is your lactational amenorrhea method. So this is reliant on 3 things. This is relying on the periods not starting again, baby being under 6 months of age, and exclusively breastfeeding. So this is what's known as your natural spacer, your natural birth spacer. And what we do as midwives, we tend not to rely on this because, or we say to women, sorry, just my light splitter in here a second. We say to women, oh, it's not reliable, but actually it is really reliable as long as those 3 things are in place. And I think that's really important to say to women, this is a really reliable method of contraception as long as those 3 things are there. So I'm just going to jump over to a table, which I thought might be quite interesting. And this is a table from Trussell. It's quite an old table now, but actually it's still very relevant. And this is the actual, if a woman didn't use a method of contraception, there is an pregnancy occurring within a year. If they use fertility awareness methods and they use it well, that could actually be 1 to 9% chance of a pregnancy. But if they use a lactational amenorrhea and they use it as perfect use, there is a 0.5% chance of a pregnancy. So you can just highlight how reliable it is if it's used properly, like anything really. If you use it, you can, for example, the oral contraceptive pill, it is reliant on you taking a pill. And actually that could fail if you miss a pill. So if you use it typically, it could be about a 9% failure rate. But actually, if there's a perfect use, it's 0.3%. So you can see, you can have a little look at this table. And it's really interesting to see the methods that are really reliable. And the most reliable method would probably be the implant, the subdermal implant. So it's great. It would be great to have a service where midwives are fitting subdermal implants prior to discharge home from hospital or in the community following the birth of their babies if they've had home births. So it's a skill that midwives can have. So we set up a postnatal contraceptive service back in 2016 in Cardiff, and we had a drive to train midwives in the different methods that are available, and all of the eligibility criteria around this, and actually so they could provide that really key information to women to make that choice. But what we found is we don't want to have that first conversation with women about contraception as soon as they've given birth. It is the most inappropriate time. Women they're tired. They don't want to be thinking about contraceptive and such, especially your long-acting methods. It seems such a committal thing to do. You know, committing to that long-acting method immediately after you've given birth is actually something that you need to have time to consider, talk it through with the partner. You know, it's really important. So we discussed this in the antenatal period, and this is key, is that planning in the antenatal period, and this is key for any postnatal care really, it should be planned and individualized in the antenatal period, ready for the postnatal period to start. And so we usually have a discussion around about 16 to 18 weeks, which seems really early, but actually it works. What we're doing is providing information, written information about contraceptive methods. And then we'll revisit it at 34 to 36 weeks with the birth planning conversations. So we'll revisit methods of contraception. And then if they choose to have a subdermal implant, we do have midwives trained in the unit that can do that prior to discharge home. Or if they wanted to perhaps wait just a couple of weeks, that's fine. We can do a fast track referral to our sexual health department as well. So we've got a really good pathway in place. If they did want the intrauterine coil immediately following birth, this is something that we did try and embed into our unit. We're not quite there yet. It's and the plan is for placenta out, coil in. So it's kind of a really good method of a great time to actually insert a coil is when you've just given birth and actually you've got good pain relief on board. You can pop it in before you suture. So it's something, what we're trying to do is in the future is to get midwives trained to do this, because what better place to kind of have it done when you're already there and perhaps you need a couple of sutures put in, you can just actually pop a coil in quickly. So it's really, and the RCOG have produced a lot of resources and information around post-placental intrauterine device insertion. So that's our future plans really for this service. But at the moment, we are actually offering it at caesarean section, that we can actually pop a coil in there as well, if that's what they would like. But again, we need that planning in the antenatal period in order for this to happen postnatally in a timely fashion, and actually that it's not making a decision on the spot. So we started this service back in 2016. So then we thought, actually, is it working? We're offering women contraception. Are they going home with it? Is it working? So we wanted to have a look at what proportion and what is the overall rate of uptake of postnatal contraception. And then we wanted to kind of link it into socioeconomic, lifestyle, pregnancy, birth characteristics, just to see if that made a difference to their decision. Move my slide. So we pulled 26,081 records over a 5-year period. So we put some variables into our maternity informatics system back in 2018, and we wanted to know women that had a discussion about contraception and the methods that they had chosen. And what we found was actually 91% of women were having a discussion around contraception prior to discharge home. So we couldn't capture if this was done in the antenatal period or the postnatal period, but actually what we found is that midwives were having that discussion. Then only 13% actually went home with a method. So we thought that was really interesting. So there's this huge gap between discussion and uptake. And the majority didn't want any discussion or didn't have contraception. That's whether they declined it or whether it was just not available for them. And then this graph kind of highlights this really. So this is what we found in this graph, is that actually over time, midwives, once we'd had this drive it was during kind of COVID, we had a big drive, but we wanted a drive to increase the discussion around contraception. So we did that, and we noticed the levels went up, the discussion was there. But these lines here are the methods. And as you can see, the methods is still that huge gap. So now we want to know is actually why women, perhaps if they're having that discussion, why maybe are they not going home with it, or why are they choosing not to have it? It's fascinating stuff. We put the COVID pandemic line in here because actually we thought this was really, really interesting. As you can see, there was a big spike. There was a big spike just after COVID around the discussions that kind of really went up at that point. And this is because community services had ceased, that people couldn't get to their GPs. So actually we were offering 6 months of the pill to go home with. So they see a big spike in the pill being taken, and then also the discussions going up as well. So it was really interesting to find that. Outcomes in relation to social demographics and to birth outcomes. this is just a forest plot which highlights this. So the side on the left-hand side, these are the women that are less likely to receive postnatal contraception. And then on the right side, these are the women that are more likely to receive it. And what we found was that the women who were unemployed, single, that they were maybe didn't have a labour, so your elective caesarean sections or caesarean birth, were more likely to receive contraception. And also if they were artificially feeding their baby, so but women that were breastfeeding were less likely to receive contraception. So we kind of wanted to explore this a little bit more. This kind of this data then has informed the next stage of the study, which is looking at asking women why, asking midwives and doctors why, and their experiences of postnatal contraception. Kind of just highlighted in just a more easier way to see, really. So we saw there was a higher contraceptive uptake with caesarean birth, with greater deprivation, with a younger age, artificially feeding, and with a higher BMI, which actually goes against what we see in practice, with that women sometimes decline contraceptive methods because they feel that they're going to gain weight. But it was interesting to see that actually the women with the higher BMI actually did choose methods. And then we have a lower contraceptive uptake with women that were married, that were older, and that they're breastfeeding or Asian and mixed ethnicity as well. So in summary then, the key inequities that we identified was that less affluent women were more likely to receive contraception, and then uptake declines with affluence as well. Less likely to receive contraception. Unemployed and single mothers have a higher uptake than employed and married mothers. And this could be, when we kind of delved into this data a little bit, delved into the research a little bit more, we tend to focus on the more vulnerable women. We focus on the women that are within the lower deprivation, and we tend to ignore the women that are married and employed, and it's that perception that they are educated and they know exactly what method they want, but actually they're almost forgotten about. And postnatal contraception should be for everybody. It shouldn't just be targeted. It should be for everybody, should have the same offer and the same information given. We also said that we thought that caesarean section is linked to a higher uptake, especially the coils, and that was stark in that data. That's because it's on our pathway, we're offering at caesarean section, and that breastfeeding mothers were less likely to receive contraception. So then we thought, let's ask women. So we put a survey out. We surveyed 150 women, and we did some online interviews with 6 women. And then we held 2 focus groups for women where English is not their first language, and that they are navigating a maternity system that is different to their birth country. So we wanted to understand perspectives for everybody. And what they found is that actually, respondents said that contraception was discussed with them in pregnancy. So we thought that was great, lovely, that it's being discussed. And they stated that the most suitable time to commence a contraceptive method was at 6 weeks. So that's what they found, is that actually they told us they would prefer to have, they feel the most suitable time would be over 6 weeks. The respondents stated that the most suitable time to start was immediately following birth, but actually more of them felt it was at 6 weeks, but only 25% of them felt that it was useful to have immediately following birth. And 69% were offered contraception following birth, with respondents either clearly declining or choosing not to initiate contraception at that time. So that was really interesting. So when asked for the reasons behind why maybe they didn't want to start it so early, they expressed concerns about using hormonal contraception and said that in the early postnatal period, and stated that they wanted to allow their body to recover from birth before commencing the period, before commencing the method. And again, this comes back down to that the myths around the safety of it in the early postnatal period, especially if they're breastfeeding. Some respondents explicitly stated that they were waiting again for recovery. And some stated that their preference for non-hormonal contraception was there, and they felt it would be safer to use non-hormonal methods in the early postnatal period. And then some respondents actually cited anxiety around their mental health when they're using hormonal contraception, and that actually in the early postnatal period it is a vulnerable time when they are experiencing different changes in hormones, and they were worried that their mental health would be impacted if they started hormonal contraception at this time. And then others had said that they had some negative experiences with around emotional well-being when they were using hormonal methods as well. Others said that they wanted to delay starting it because they felt that they had good provision with lactational amenorrhea, and that was really good to hear that there were some respondents that were relying on this method. And others said that they were not planning to resume any sexual activity anytime soon, as their reasons for not starting, which is fair enough. So then we asked the doctors and we asked the midwives. We want to get a kind of really understand of all of these experiences. So we had 221 respondents for the survey for the midwives and 34 for the doctors. And we did some online interviews with 6 midwives and 7 doctors. And what they told us is that actually they felt that contraceptive discussions should be taking place in the antenatal period, and that actually, or during the community visits, not in that kind of immediately following birth. And most midwifery respondents raised concerns around the offer of postnatal contraception immediately following birth for the first time. And they stated barriers, and these are your competing priorities. And we know that and this is what when Sue mentioned about postnatal care being the Cinderella of the services. There is a lot to discuss in the postnatal period, in the early postnatal period. There's a lot of clinical priorities, and they're all competing. They're all just as important. So actually, midwives felt that is this the most appropriate time to discuss it? And also the perception that new mothers do not want to engage in this discussion, and they may have that overload of information in that postnatal period. So this is why it comes back to the importance of antenatal planning. They further suggest that reduced staffing, limited time, lack of training and confidence around postnatal contraception were all additional barriers to this. And they gave some potential facilitators here, again, early antenatal discussions, to support decision-making, contraceptive training with midwifery competencies, but making sure it's culturally sensitive as well. So they didn't feel confident to discuss contraception with women that maybe they have special cultural needs and sensitivities, and actually, midwives felt that maybe they didn't know how to have that conversation. And also then your practicalities of ward stocks and getting prescriptions and PGDs and all of the things that come with that. But there was numerous comments around the importance of an MDT approach. You can't just do this with midwives alone. It has to be an approach. So using involving your pharmacies, involving sexual health, involving your obstetricians. This has to be everything centered around the women and their partners as well. And it was we wanted to improve information and education for parents with direct links to sexual health. So if they don't want to have it there at the time, then we can signpost them to the relevant people. And then there was obviously the time pressures and the lack of knowledge, but also the funding and commissioning services. So having the funding and commissioners really behind this and having this written into Women's Health Plan will push this forward. So again, in summary, we found that it was lack of trained staff for subdermal implants and PPIUC. So this is the postpartum, the post-placental intrauterine devices insertion. And there was lack of trained staff on that. So there was a call to increase the staff training, increase the midwifery training for subdermal implants. Then it's the myths and misconceptions. So it's that kind of perceived that women don't want it in the early. But also, is it because they're scared? Is it the safety around? Are they scared that actually they feel it's not safe for them to take? So it's myth busting that we need to look at, especially with breastfeeding. The progesterone only methods are very safe in breastfeeding. And then also the cultural beliefs as well. Then we've got the competing priorities of the busy postnatal ward, the busy postnatal care midwife, trying to kind of do her very best, his or her very best in providing postnatal care. And then sometimes these physical recovery trumps the kind of contraception then. So we're more focused on the kind of priorities of physical recovery than we are on the actual methods of contraception. And then provider bias as well. So age, marital status, employment status, that actually, we're talking about that forgotten cohort of women that don't get offered the contraception because they're perceived to know it all, and they don't. So the best practice would then be supportive leadership on this, so kind of really driven from kind of your governments as well, and having midwife or nurse champions available just to kind of have somebody there who's driving this forward, but it being a multidisciplinary working group as well, and it being led by the woman. This is really important. The women has to be at the core of all of this decision making, having access to women midwives having access to training and education around this, and that there is evidence, that there is access to evidence that is culturally appropriate, and that they're in the right languages, that women can really make that true informed consent in the antenatal period. And I'm going to stop talking there. Thank you very much. I'm going to stop sharing my screen.
That's lovely. Thank you so much, Judith. That's a huge amount of information. Now, any of you have got questions, and I know there's quite a lot of discussion going on in the chat box, if you feed them through to Paul and they'll come through to Judith. Okay, so without further ado, thank you for that, Judith, and we'll come back to you all both at the end. I'm really so delighted to welcome Dr. Lesley Turner, Senior Teaching Fellow in Midwifery undergraduate team at the University of Southampton. She's had many roles within higher education, and it all began, I think this was really interesting, from her teaching parent education. Lovely start. Her role has always been closely linked to clinical practice. She's overseen the planning and quality of clinical placements for students. She's also currently developing a research programme on maternity staffing, having completed a PhD in 2024. And she's also a co-applicant on nationally important workforce studies and has excellent publication track record. And you will be able to, on your resources list, you'll see a previous presentation from Lesley. So you're getting the next bit of the story, which I think is absolutely lovely. So Lesley's going to share her research on midwifery understaffing and postnatal care quality. Thank you so much for joining us, Lesley. The screen is now yours.
Thank you, Sue. So good evening and thanks for this invitation. The work I'm presenting today is about maternity staffing and how this relates to the quality of postnatal care. I'm going to have to advance my screen for some reason. Hold on. Technical problems. Everyone's able to help me.
I think Angela might.
Yeah, I will do. Thank you.
We hope the gremlins haven't arrived.
Yeah. Seems to be sharing. Start this again. Apologies, everyone.
No worries. It's so naughty old gremlins.
No, it was perfect in the rehearsal.
Yes, it was. Yeah, it'll be.
So I was all ready to go. Let's try that again. Not quite what we want, but is that sharing now? Yes, I think so. Are we good? Okay, lovely. Apologies, everyone. So we know that staffing is important. So 47% of the entire NHS budget is spent on staff, accounting for over £56 billion every year. And it's important that skilled staff are available at the right time and at the right place to contribute to safer care and improve the care experience. But we know there's variation in how maternity services are staffed across the UK. And this includes not just the staffing levels, but also the composition of the workforce, how they're organised and how they're deployed. And this variation may be warranted by differences in the populations and the services. We know that anecdotal evidence of unsafe staffing is not sufficient to bring about a change in policy, but staffing decisions should be carefully planned and based on evidence, which is where my research comes in to try and fill some of this gap and expand the evidence base, especially in postnatal care. For now, we don't have a mandated ward level staffing ratio or minimum levels in maternity services in England, other than the requirement for one-to-one care in labour. In England, we ask healthcare providers to deploy sufficient staff to provide safe and effective care. And this is enshrined in the NHS Constitution and monitored by the Care Quality Commission. So first we need to define quality. And this definition comes from the World Health Organization in 2018. And the three main dimensions describe care that's effective, so it's of clear benefit, it's safe, avoiding harm, and provides a positive experience. Person-centered care responds to individuals' preferences, needs, and values. The first 2 completed studies looked at the experience of postnatal care in mothers in 2018 and 19. And for those studies, I was able to download individual responses to the maternity survey and looked at whether mothers on postnatal wards had delays in their discharge, whether they were helped when they needed it, whether they had the information and explanations they needed, and whether they were treated with kindness and understanding. And I matched this to staffing data for the same time period. And I chose postnatal care because this is an area of dissatisfaction among mothers and an area where staffing can be variable. I found in those studies that trusts with higher levels of maternity assistants and registered midwives had higher rates of women saying they had a positive experience of postnatal care. Next, I went on to choose to look at postnatal readmissions. So readmission rates are currently 3.3% in England and Wales. That's maternal readmissions. And I found just 2 studies in the international literature on postnatal readmissions in relation to staffing. So readmissions and why they matter. I also chose to look at them because they're well recorded in hospital systems and they're a useful marker of care. They matter because they're costly in terms of finance and women's experiences. In terms of finance, there's the cost per bed day, the cost of staffing, the cost of treatment, and the increased service activity. And for women and families, there's disruption, additional treatment, separation from their family, stress, impact on bonding and infant feeding, additional travel and separation from their other children. So these are the methods that I used. I completed a secondary analysis of a large longitudinal study, and this involved 64,250 postnatal mothers who gave birth between 2015 and 2020 in 3 hospital trusts in England. I was able to access anonymised individual patient data, and this showed whether the individual women were exposed to understaffing during the first 2 shifts of their stay. I was then able to screen the data to see if they were readmitted within 7 days, within 30 days, or they were not readmitted at all. And I was able to account for some of the other factors that can make a difference in readmission other than staffing. So I was able to account for the mother's age and the type of birth. And I was also able to look at service level factors like how busy the unit was for admissions and discharges, and the staff composition of midwives and support workers. And to calculate understaffing, I compared this to the average level for the unit. And here are the results. So within the 3 services over the time period, 2,903 mothers were readmitted within 30 days of discharge. So that's 4.5%. And of these, most of them were readmitted within the first 7 days. I found that below average midwifery staffing was associated with higher rates of postnatal readmissions at 7 days of discharge. This was an 11% increase and was statistically significant. The effect was smaller when I looked at 30 days of discharge. It was an 8% increase and not statistically significant. So this was for the registered midwives, but there was no clear relationship with the maternity assistants understaffing and readmission rates. The most common reason for readmission was infection of any type, followed by bleeding. And the rates of readmission varied by the method of birth, as you might expect. I wasn't able to look at the potential mechanisms by which understaffing could lead to readmission, but we could speculate these to be potentially rushed care, poor discharge information, perhaps some were discharged too early before their complications were noted. There could be less breastfeeding support than is ideal, potentially leading to mastitis, the potential for insufficient wound care or monitoring, possibly signs of deterioration could have been overlooked, or there could be poor communication with the community teams or an incomplete handover. So that list is speculative, but trying to think about how they could be linked, these 2 things. And my final study is about safety incidents. So in many systems, they're called datasets, so datasets incidents. And I looked at how many of these occurred in relation to the staffing levels on the very same day in maternity services. And these incidents included maternal and neonatal deaths, stillbirth, labour events such as hemorrhage and perineal tear, discharge incidents and medicines errors. It's important to learn from these events and think about the contributing factors. So this study was not just in postnatal care, it was across the service. It's always difficult to estimate the true extent of incidents because they do rely on staff reporting, and we know that staff don't always have time to report their datasets incidents. So we need to bear that in mind. So this builds on a scoping review that I did in 2020, which had quite mixed results. So on the left-hand side of the line were all the studies that showed or indicated that having understaffing was linked with poorer outcomes to the left of the line, and those to the right of the line showed effects that were either no difference or effects in the opposite direction. So this really led me to the aim of this study, to look at the midwifery staffing and the rates of incident reports on a daily basis. So this is more detailed than has been studied before. The methods I used for this study were very similar to the other study in that I accessed secondary data, but I was able to use staff rosters and the details of patients' submissions, discharges and outcomes for 2015 to 2020. And the total was almost 107,000 admissions. I was able to look at staffing information from the roster, and I converted this to hours per patient day, which is made up of the total worked seconds for staff members and the total occupancy time for mothers and babies. And then I accessed the daily reported incidents. And the main outcome was any incident graded as harmful to patients. I was also able to account for other things happening on those days. So the age of the women present, how many of them had medical conditions or comorbidities, whether it was a weekend or a weekday, and also the pace of the service in terms of how many people were admitted and discharged. And the results are summarised very briefly here, but I found that the actual staffing levels varied between the three organisations. And also the harm incidents varied between them, from 2.1 per 100 admissions to 3.0 per 100 admissions. In the purple block, we can see the results, which showed that understaffing by registered midwives was associated with an 11% increase in harm incidents, and this was statistically significant. In the black block, I show that understaffing by maternity assistants was not associated with an increase in harm incidents. So there was no relationship there. And in the green block, I found that higher patient turnover, so admissions and discharges, was associated with a 19% increase in the risk of harm incidents. And this was statistically significant. This had not really been looked at before, so it was a surprise finding, but quite stark. So these results tell us that the days when there are fewer midwives or higher numbers of admissions and discharges are associated with greater harm to mothers and babies. Many of you won't be surprised by this. I went on to look at specific types of incidents and the coefficients, so the numbers show how the rates of incidents change, and the numbers in brackets are the confidence intervals, which show us how certain we are about the estimate. The result at the bottom in red shows that staff were actually reporting low staffing and high workload. They reported these as incidents in themselves. And I found that their reporting was associated with actual low staffing. So the numbers that I calculated for the midwives' hours were very much related to when the midwife said that they were running short. So that would be expected, but it was reassuring to see that those things tallied. Many of the estimates are above 1, suggesting that the specific incidents occurred more often when maternity services were understaffed. Many of these were not statistically significant. but the biggest effects seem to be in delays in care and discharge incidents. The results when we looked at maternity assistance were mixed. There was no really clear effect going on there. Then I looked again at patient turnover, so the number of admissions and discharges, and this seemed to be really clearly linked to specific incidents. So a 51% increase in discharge incidents and a 22% increase in rates of delayed care when there are more people being admitted and discharged than normal. So here are the conclusions from this study really, is that I was able to find an association between the understaffing of registered midwives and incidents involving patient harm. So the implications of this are to continue to invest highly in registered staff and to continue safeguards on understaffed shifts. I saw that high turnover was associated with higher reports of harm incidents and other incidents. So the implication could be to adjust staffing where we're predicting a high turnover of patients, if that's possible, and to offer support to mitigate risk. One approach could be to set the baseline staffing slightly higher so we're able to deal with these variations, such as peak demand. This research is not able to tell us what the safe staffing level is or recommend an optimal level. However, the use of routinely collected data in future could help us to do this using mathematical models. But this study does help us identify the effects and provides justification for the prioritisation of staffing. So just to highlight the papers that I've discussed today, and these are available on your resources. And finally, a plea for some help, please, is that I'm planning future work using large NHS data sets to look at the workload of midwives in current NHS settings and how this fluctuates from shift to shift and week to week. I'm keen to understand more about the workload itself, perhaps how much of this is predictable and unpredictable. And by understanding this better, it may be possible to smooth out some of the workload or plan for this better. I am in an early stage of this research proposal, but I would love some practitioners, managers, service users to guide me with their thoughts so we can make and design the best possible research. It might also be useful to link with digital midwives so we can see what we can extract from the data rather than collecting new data. So if anyone on the call is interested in a short chat or email correspondence about this, I would love to hear from you. And my email address is on the next slide. Thank you.
Wow. Gosh, I think my brain might be getting a bit full. My word. This is fantastic. I think thank you to both of you for sharing really some very hard-edged research, actually. I mean, Lesley, as the most recent one just now, I mean, these are the things we kind of feel must be happening, and it's so nice. Well, it's nice and it's not nice, isn't it, to be thinking about things going wrong for women and their babies and families, but it's good that it's being picked up, the effect of that low staffing and also the high turnover of women. I mean, it sort of, for some of us who were trained a long time ago when women stayed in a wee bit longer, you would think it does feel that the changeover is very quick nowadays. And I was kind of a bit stunned with that, really. So we are having some questions in. If you have questions for Lesley or Judith, please throw them in. We've got a little bit of time. We're going to run over a bit and be a bit naughty, but we won't worry about that too much. So we've got Jess. Hello, Jess. And Jess says, apologies if this has been clear. Connection has been bad. Was there any consideration for staffing in the community, like doing postnatal visits at home, clinical? And were you able to see those numbers in regards to readmission rates? Because that's another complication for midwifery, isn't it? We're kind of half and half here.
I would have loved to have looked at that, but unfortunately the data set I was able to access was only for the inpatient activity and the inpatient rosters. The rosters can be more complicated in community, but it's not to say we shouldn't do it in future, because we certainly should. I just need to work out how to do it. But yeah, so unfortunately it didn't, and that would also impact on the readmission rate, is the degree of community care, and that would be a limitation of our study, really, is that we couldn't allow for that.
And I think that could be quite interesting because, I mean, postnatal care, again, do women get visited every day in the postnatal period at home? I suspect they don't. And I think there's a lot of care that goes on that's provided by care assistants, which is fine in a way, but it's not. I think the indicator that you were using in that shortage of staff of MSWs was not as bad with effect as a shortage of midwives was quite telling, really, for postnatal care, whatever. So that was very helpful.
It certainly contributed to the care experience, so that was really positive, but not
Yes.
the safety aspects. So
Yes. So supporting breastfeeding, for
yeah,
example.
certainly there was some positive results there.
Yeah, I wouldn't kind of deny what the value of MSWs, because they're doing a good job, but it's kind of the qualified staff who they might be reporting to are the sort of fundamental people there. So I don't know if anyone's listening who wants to start spreading the word and become a sort of feed in to Lesley, whether it's sort of community, how she could figure out the community aspect of this. I think the hospital aspect is going to be fairly complex as well. Is that part of the project work that you're doing at the moment?
At the moment, I'm considering workload, so looking at it from a different angle. So we've looked at the staffing angle, but actually, is there something about the workload that we need to understand better as to why our units closing, our birth centres, our home birth services, could that be prevented somehow? It might be quite idealistic.
Well,
unless we look at the workload, then it's hard to see how variable it is, and can something be done differently.
And I'm always sort of thinking at this point, we need to be providing the care that we'd like. Really. I mean, what would you like in your care? This is just a regular thing, because these women are like you and me. They're not some other people. And what your research makes me really think of that, even underlining. And also does Judith, I have to say. Got another question from Jess. Oh, it's a follow-up. Hello, Jess, again. And just very interesting, having worked in community covering postnatal care, there are so many competing factors. Absolutely, you've nailed it, Jess. And Shaza Castle. Hello, Shaza. I'm definitely supportive of more contraceptive conversations, but would inserting an IUD so shortly after birth increase the risk of misplacing, stroke, dislodging the device? That's definitely one for you, Judith.
Yeah, absolutely. So, when a coil is fitted normally, so that when in not a postpartum uterus, there's about a 1 in 20 chance of expulsion. When it's fitted postpartum, immediately following birth, there's a 1 in 7 chance. So it is more likely to be expelled. However, there is a chance it can stay in as well. So you have to just weigh everything up, really. And we do use quite a strict criteria. So we wouldn't, for example, place one in if there's an ongoing PPH. Obvious reasons, it's going to fall out. Or if the lady's been in the sepsis pathway. So there is quite a strict criteria, really. But we have had lots of really great cases whereby women have had a coil fitted and it's remained in for 5 years and there's been no issues at all. So there is always a chance of expulsion. It is always going to be greater because we're waiting for that uterus to involute and we're waiting for that cervix to kind of close. So there's always going to be a chance, but actually it's not as bad as we think.
And I guess in skilled hands as well, that must make a big difference for the expertise of the person putting in. Thank you for that. Okay, and we've got Nikki, student midwife, saying, hello, Nikki, saying, I know student midwives are supernumerary, but knowing how big a role we play in postnatal wards, I would like to hope that we contribute to good postnatal care. Well, we're all nodding. because though you're supernumerary, you are learning the skills of postnatal care. Absolutely. I don't know, did any of that come through, Lesley, in the research on, were you counting student midwives as well in the numbers?
Yeah, we didn't count student midwives in those numbers, but they do certainly contribute to postnatal care without a doubt. So yeah, I think we're very careful about not including them in the workforce numbers because they are there to learn and they should be free at any time to go and take up a learning opportunity, and the staff should be supporting them to do that. So yeah, so they weren't included in that research, but without a doubt they do contribute. So.
Absolutely. Well, I mean, how else are you learning postnatal care but working alongside your midwife? Absolutely. Thank you. And we've had Jackie Cooves. Hi, Jackie, who says, Lesley, what's your view on the increasing use of registered adult nurses on postnatal wards? Did your research work separate out whether the registered staff on postnatal ward were nurses or midwives, or were they all grouped together for the purpose of analysis? Do you know, our participants asked some fab questions. Thank you for that, Jackie. Lesley, in a word.
That was a very good question. So go back to the second part, is that they were grouped together because that's how the data was arrived at. But there were very, very few registered nurses in that data set because it was between 90, it was the period just before COVID. So it was some time ago now that data was available to us. But I have been asked that more and more actually, in terms of people saying, for your next project, can you look at this, please? And also look at those support workers' contributions too, because many of them are trained to really high levels now and are performing some quite complex contributions now. So I did try and look at them. They were grouped together. There was a small amount there. I think we need to look at the workforce we have. And registered nurses are not the same as registered midwives. They've got a different skill set. However, we don't really want fragmented care where people are having care from a large number of people. So I think that needs to be weighed up as well. So although people can do various parts of the role, there is a lot of value in having the same person. So I didn't look at case loading, but so that there's different contributions, isn't it? So you might be able to do some of the same work, but actually are you slicing up that lady's care pathway into multiple pieces?
I think the case loading issue is quite an interesting one.
So it is interesting. I think definitely, in the future that might be something we're looking at more. So certainly in things like high dependency units, in recovery, in some parts of postnatal care. And I think it's something we need to account for in future if we're having more registered nurses. So we've got the children's nurses in the transitional care units. So I think it's something we do need to account for more.
And then we have, nurses and midwives and neonatal nurses are all in low. We haven't got many of any of them. We need lots of more. That's fabulous. Thank you. I was just wondering, actually, Judith, with this, the whole concept of the and you focused a lot more on contraceptive information, which was really useful because I think that's an area where most of us as midwives might be a little bit rusty. So it was really useful to have that, and with that strong evidence base, really helpful. Did the staff or were you aware of the amount of time that was required in this extra focus?
And so time for learning or time for
more time for discussing with women, because you said, and I thought this was really interesting, and I loved that, the fact that you introduce postnatal care and postnatal contraceptive really early in the antenatal period, because you must hope, because one of my questions would have been, when should we look at postnatal care? And obviously it's right from the beginning, whatever.
Yeah.
But thinking about that, you're going to have that discussion somewhere. And were people saying to you, oh, we haven't got time to do it, we're far too busy, we can't do all that as well?
Yeah, we hear it all the time saying we haven't got time, or they'll use a checklist. So it'll just
Oh,
be like it'd be
ticky tick.
that checklist of just ticking it off. You've read out the sentence and you're ticking it off, and actually that's not meaningful in any way. So it's that planning in the antenatal period. Like I said, it's that real discussion, the written information given in the language of the woman that she can understand. We use animations as well. So Scotland have got a great animation around postnatal contraception and about pregnancy spacing, and actually just using our maternity informatics system. So we've now moved to Badgernet, which is we've gone paperless. We can actually input the leaflets and the animations within that system. So it'll ping to the lady's phone so she can see it, she can read it whenever she wants. So what we've got is that that readily accessible information. So actually, when we are having that discussion in the postnatal period, it shouldn't take too long. All you're really doing is confirming what she would like. So it shouldn't take, and then you're just assessing the eligibility and getting consent. All of the planning and the discussions and the actual key questions would have been answered in the antenatal period. So really, it shouldn't take as long as going through every single method and providing it for the first time. It should be a bit quicker.
Fabulous. Well, thank you. Now we've got haven't any more questions so far. Shazza says, thank you. Very interesting to know. Jackie says, thank you both for your presentations. Really interesting and important work. Yes, absolutely. And Nikki says, thank you, all very interesting. And I'd say, thank you, all very interesting. And I have to say to the audience, we've run over a little bit, so I hope you forgive me. And us, because we're all working together here. But I want to say a big thank you to Judith and Lesley for joining us this evening in their own time. And you know, they're all busy, they're very busy women, and Judith is waiting just in case she's called out this evening. So thank you for coming along in spite of that. That can be quite distracting as a speaker, I have to say. But she's just balancing it like we all do, but fabulously. And I want to say also thank you to Angelo, who's making sure this is all beautifully taped. I might add, he's in Australia doing this. Can you believe the wonders of all this technical stuff? But he'll make sure it's recorded beautifully. So for those of you like a 6 o'clock in the morning Friday podcast, it'll be available, and it'll also be available in the newsletter that comes around on next Wednesday, so you can have a quick link. Now, if you haven't signed up to the Maternity and Midwifery Forum newsletter, it's useful to do so, because there's usually some nice little tasty articles in there, but also you have the quick links into the maternity hour and also the festival and everything. And I'm going to say also thank you to Paul, who's fed through the questions. Oh, and I've got thank you from Angela Eugen too. Thank you, Angela. And also next week we've got Dr. Anna Byram is our guest chair, because I'm away only for a week. And I just want to say another huge thank you to our lovely audience. What fabulous questions you've given us. Remember, spread the word, because Lesley wants to do even more work in this and really delve in. And I know Judith will also want to spread the word on her project, because this is something that we need to know about to support mums and really get them information to make good choices. And don't forget this old paper that's on your list as well. That'd be very handy. And then also, I'll say to you as my final word, take care of yourselves, because you're important. You need to be well and look after yourself in order you can look after the mums and babies and families and your colleagues as well. So we'll see you in the same time next week. Take care.